we'll be breaking down all major concepts covered on the exam. Usually when we talk about a medical diagnosis, there's this expectation of precision. It feels a bit like engineering.
Right, like it's a math problem with one correct answer.
Exactly. You break your arm, the x-ray shows that jagged white line, and the physician just points at it and says, there it is, broken.
Yeah, it's a very comforting binary, honestly. The pathology is totally visible, easily categorized, and the next step is just obvious.
But then you step into the world of dermatology, specifically the papulosquamous diseases, and suddenly that x-ray machine is entirely useless. We're looking at a diagnostic landscape that is, well, incredibly murky. I mean, a red, scaly rash on the trunk or the limbs could be a dozen different things.
Oh, absolutely.
And as a medical student staring at a multiple-choice screen, all those rashes just start to blend together.
They do, and this is key, one minor detail, like the specific location, the shape of the border, or even the presence of a single white line, it changes the entire pathophysiology, not to mention the prognosis and treatment.
It changes everything. I'm Harvey, and I'm joined by Donna. We are two MCCQE reviewers, and we're here to help Canadian medical students feel fully confident and comfortable with the exam review process.
That's right. And before we start spotting those tiny dermatological details, we do have a quick piece of housekeeping.
Right, the disclaimers. So this deep dive is based entirely on reliable StatPearls articles. But please remember, this is strictly for medical education, not medical advice. Any clinical decisions must involve a qualified healthcare provider.
Exactly. So our mission today brings us to section S10 Dermatology, specifically those papulosquamous diseases we were just talking about. We're unpacking two heavily tested high-yield conditions today, Lichen planus and Pityriasis rosea.
And the goal here isn't just to, recite a list of symptoms. We're going to master the definitions, the presentations, diagnoses, management, and most importantly, the common traps the MCCQE will use to treat and trick you.
Because they will try.
They absolutely will. So we need to look at the why behind these diseases, so you aren't just memorizing facts, but actually understanding the mechanisms. Let's start with Lichen planus. What is actually happening in the body when this condition kicks off?
Well, Lichen planus is an inflammatory autoimmune condition. It affects both the skin and the mucous membranes. The exact initial trigger isn't always known, but the mechanism is pretty clear.
Okay, so what's the mechanism?
It's a cascade where the body's own immune system targets the basal cells of the skin.
Right. And on the exam, you're going to get a clinical vignette first. The patient walks in, and you have to recognize the 6 Ps. I remember drilling these. The 6 Ps are purple, polygonal, planar, pruritic, papules, and plaques.
Yeah, that's the classic list. But let's break down why those specific visual cues happen. Like the purple or violaceous color isn't just a random shade of red.
It's a very specific purple, right?
It is. It's due to the specific type of inflammatory infiltrate and the way light interacts with melanin that has literally dropped deeper into the skin layers. And polygonal just means the borders have sharp angles. They aren't perfect circles.
Okay, and planar is a defining feature too. These lesions are flat-topped. They don't dome up.
Exactly. And the reason they're flat is because the immune cells are forming this dense, flat band right underneath the surface, which effectively restricts any upward growth.
That makes so much sense.
Right.
And then pruritic, obviously, means they itch intensely. They start as small papules, which are, raised bumps smaller than a centimeter, and over time, they can coalesce into those larger plaques.
Right, but the exam won't just say the patient has flat purple bumps everywhere. Location is a massive clue here. Lichen planus loves the flexor surfaces.
So we're talking about the inner wrists, the ankles, the lower back, and the shins.
Spot on. And if you look really closely at those flat-topped papules on the wrists, you'll often see a distinct feature overlying them called Wickham striae.
Wickham striae, those are the little white lines, right?
Yes. They're these delicate, lattice-like networks of white lines sitting directly on top of the lesions, and they are especially visible on the buccal mucosa, which is the inside of the cheeks.
Although finding those white lines on the skin lesions during a physical exam can be kind of tricky with just the naked eye.
It definitely can.
So if you use a dermatoscope, which the exam absolutely loves to test, by the way, you are looking for a very specific pattern. Dermoscopy will reveal those Wickham striae as a distinct network of white lines, but you will also see red globules at the periphery of the lesion.
That's a great high-yield detail to keep in mind.
Now, there's another classic physical exam finding associated with Lichen planus that students sometimes struggle to conceptualize, and that's the Kogner phenomenon.
Yes, the isomorphic response.
Right, so think of the Koebner phenomena like invisible ink on a piece of paper.
Yeah.
The paper looks totally blank, but the chemical potential for the message is already sitting there, embedded in the page. It just needs a catalyst like heat or a specific chemical to reveal it.
I like that analogy.
Thanks. In Lichen planus, the patient's skin is that paper. The autoimmune potential is kind of simmering right below the surface everywhere on their body. So when a patient violently scratches their extremely itchy skin, that physical trauma acts as the catalyst. It reveals the invisible ink.
Exactly. The physical trauma localizes the inflammatory response. So new lichen planus lesions will form exactly along the linear track where the skin was scratched or injured. The immune cells basically rush to the site of that microtrauma and initiate the autoimmune destruction right there.
So let's dive deeper into that destruction,
Yeah.
because if my immune system is supposed to fight off foreign invaders like viruses or bacteria, why is it suddenly attacking my own healthy skin cells? What's the trigger there?
Well, it comes down to altered self-antigens and T cells.
Yeah.
The prevailing theory is that an exogenous agent, maybe a virus, a drug, or an allergen, enters the body and binds to the surface of your epidermal cells. And this alters the ID tags on your cells. Your immune system gets confused. Cytotoxic T cells cross-react because they no longer recognize those basal keratinocytes as self, so they attack. They trigger apoptosis, which is programmed cell death, right at the base of the epidermis.
And this brings us to some highly testable MCCQE associations. Because this is an immune response often triggered by an outside agent altering our cells, we have to talk about hepatitis C.
Oh, absolutely. This is huge. Patients with lichen planus are up to 5 times more likely to test positive for hepatitis C compared to the general population.
Wow, 5 times.
Yeah. And conversely, if a patient already has hepatitis C seropositivity, they're 2.5 to 4.5 times more likely to develop lichen planus. The chronic viral infection basically keeps the immune system in a hyperstimulated state, which increases the chances of these cross-reactive T-cell mistakes.
So as a test taker, when you're reading a vignette about a patient with itchy, flat-topped purple bumps on their flexor wrists, you should actively scan the rest of the text for a history of IV drug use, jaundice, or elevated liver enzymes.
Yes, the exam writers love connecting dermatology to hepatology.
Always. Now, there's also a major association regarding the oral variant of lichen planus, right? It's strongly linked to contact allergies from dental metals.
Right. Things like mercury, copper, and gold dental restorations can act as haptens.
Remind us what a hapten is.
Sure, hapten is a small molecule that isn't inherently immunogenic on its own, but when it binds to a protein in your oral mucosa, it creates a new complex that your T cells suddenly view as a threat.
Oh, so it triggers a type RV delayed hypersensitivity reaction.
Exactly, and what's interesting is often if you just remove the metal restoration, the oral lesions clear up entirely.
That's fascinating. Now, because we're talking about T cells actively destroying the basal layer of the skin, we really need to touch on histopathology. Biopsy findings are super high yield on the exam. The first buzzword you'll see is hyperkeratosis without parakeratosis. Let's translate that.
Good idea. So hyperkeratosis means the very top layer of the skin, the stratum corneum, is thickened.
And parakeratosis is when the cells in that top layer retain their nuclei, right? Because the skin is turning over too rapidly, rushing the cells to the surface before they fully mature.
Exactly. But in lichen planus, you do not see parakeratosis. The skin is thickening, but the cells have normally lost their nuclei. It's a slow, steady buildup.
Right, no rushed cells.
Yeah. You will also see an irregular thickening of the stratum granulosum, which is the layer just below the surface. But the most defining feature on a biopsy is the presence of sawtooth reet ridges.
Ah, the sawtooth reet ridges. So reet ridges are those downward projections of the epidermis into the underlying dermis. They normally look like gentle rolling waves.
Right. But because the cytotoxic T cells are destroying the basal layer right at that junction, the whole structural architecture just collapses. Those gentle waves turn into a jagged sawtooth pattern.
And the pathologist will also note an interface dermatitis, right?
Yeah. Yes. That simply means there's a dense, band-like wall of lymphocytes sitting exactly at the interface, the dermal-epidermal junction, carrying out the attack. And because the basal cells are being systematically killed off, you'll see dead, apoptotic keratinocytes dropping down into the donus below.
And we refer to those dead cells as Savant bodies or colloid bodies, correct?
You got it.
Okay, I want to challenge the diagnostic process here for a second. Let's say a patient comes in with a rash that looks exactly like lichen planus. Flat, purple, itchy papules. But the vignette mentions they started taking an ACE inhibitor for their blood pressure a few months ago.
Okay.
If a drug triggers this, Is it the exact same disease process or just a mimic? Because if it's an allergic reaction to a medication, shouldn't we see an allergic cellular response instead of just this T-cell autoimmune process?
You've hit on a classic board trap. Drug-induced lichenoid eruptions look incredibly similar clinically, but the mechanism and the histology actually differ slightly. First, idiopathic lichen planus, the true autoimmune version, loves the flexor wrists and ankles. But drug-induced eruptions are usually photo-distributed. They show up on sun-exposed areas and are highly symmetric.
Oh, that's a great distinguishing factor. And what about those white lines, the Wickham striae?
Drug-induced eruptions often lack them entirely, but the really definitive answer is in the biopsy, which addresses your point about the allergic cellular response.
Okay, so what does the biopsy show?
Well, if you biopsy idiopathic lichen planus, you rarely see eosinophils. But if you biopsy a drug-induced lichenoid eruption, you will see eosinophils mixed in with that interface dermatitis. Eosinophils are heavily involved in allergic reactions, so their presence is a huge clue.
That makes perfect physiological sense.
Oh.
The drug is acting as the allergen, drawing in the eosinophils. And the common culprit drugs to look out for in the vignette are antimalarials, ACE inhibitors, and thiazide diuretics, right?
Exactly. And notice the timeline, too. There's a latent period. The patient might have been taking the blood pressure medication for several months or even up to a year before the rash erupts. It takes time for the drug metabolites to accumulate and alter the cellular antigens enough to trigger the immune system.
Okay, so that covers the standard presentation and the drug mimics. But lichen planus also presents in several distinct clinical variants beyond the standard skin lesions, doesn't it?
It does. Oral lichen planus can present as a reticular pattern, which are those painless white lacy lines we mentioned. But it can also present as an erosive and atrophic pattern where the mucosa breaks down into incredibly painful ulcers.
Ouch. And there's also vulvovaginal gingival syndrome, which involves erosive lesions on both the oral and female genital mucosa.
Right, and that variant is genetically linked to the HLA DQB 102.01 allele.
Which is basically the gene that provides instructions for making the major histocompatibility complex proteins, the ID tags your immune system reads. So this specific allele makes the immune system highly prone to misreading those tags in mucosal tissue.
Exactly. And the disease can also target the hair follicles and the nail matrix. Lichen planopilaris causes progressive scarring alopecia on the scalp. The immune system literally destroys the hair follicles permanently.
That's devastating.
And the nails. You can see 20 nail dystrophy. The nails thin out, they develop longitudinal ridges, and they can form a dorsal pterygium. That's a V-shaped extension of the proximal skin growing outward over the nail plate because the underlying matrix has been damaged.
So how do we actually manage all of this? For standard cutaneous lichen planus, I understand it's surprisingly self-limiting. Like it usually resolves on its own within 1 to 2 years.
It is, yeah. But the pruritus, the itching, is so severe that you really have to intervene to treat the symptoms.
Right, you can't just let them suffer for 2 years.
Exactly. So the first-line therapy is super potent topical steroids like clobetasol 0.05%, applied twice daily for 2 to 4 weeks. If the rash is diffuse all over the body, you can escalate to systemic oral corticosteroids.
Makes sense. But we need to pause on the management of the oral variant, because this is a vital MCCQE trap. When you're a medical student, your instinct is to treat any abnormality you see.
It is, yeah.
But asymptomatic oral lichen planus, specifically those painless white reticular lines, should never be treated. Why do we hold back? I mean, the urge is to prescribe a steroid immediately.
It's a great question. Oral lichen planus, unlike the cutaneous version, is chronic. It rarely resolves forever. If you treat painless lines with high-potency topical steroids in the mouth, you might induce a temporary remission, but it will relentlessly relapse the moment you stop the medication.
Oh, wow. So you're just committing them to endless steroids.
Right. And over time, the constant use of mucosal steroids leads to mucosal atrophy and a high risk of opportunistic infections like oral thrush. The burden of those adverse effects is just far too high to justify treating something that isn't causing the patient any pain. You only treat symptomatic, erosive, or painful oral lichen planus.
Treat the patient, not the physical finding.
Exactly.
Even when the lesions do heal, though, there are complications. The skin lesions often leave behind grayish-brown post-inflammatory hyperpigmentation. Because the melanin drops deep into the dermis during the inflammatory attack, it just takes a long time for the body to clear it out.
Right. Hair loss on the scalp is permanent because the follicle itself is scarred over. And the most dangerous complication involves the mucosal variants. Erosive oral or esophageal lichen planus carries a documented risk of malignant transformation into squamous cell carcinoma.
Wow, so the chronic inflammation and constant cellular turnover eventually lead to genetic mutations. You really have to monitor those patients long term.
You do. So we've been analyzing a chronic internal autoimmune battle. Let's contrast that by looking at an acute self-limiting papulosquamous eruption that is heavily tied to external viral mimicry.
Pityriasis rosea, or PR.
Yep.
PR loves to mimic other, more dangerous diseases on the boards. The exact cause is still unproven, but the evidence heavily points to an infectious origin. Specifically, it's believed to be linked to the reactivation of latent human herpes virus 6 and HHV7, or it can be preceded by an upper respiratory tract infection.
Right, and this viral link explains why patients often report a viral prodrome, so fever, sore throat, joint pain, and fatigue days or even weeks before the rash ever appears.
And the timeline of the rash is highly structured and heavily tested. It almost always begins with a single large lesion called a herald patch or a mother patch.
Yes, and this primary plaque shows up on the trunk or neck in about 50 to 90% of patients.
It's called a herald patch because it heralds the storm that's about to arrive. Because 1 to 2 weeks after that initial patch appears, a secondary eruption occurs. The patient breaks out in secondary crops of smaller, oval-shaped macules and papules.
And the spatial distribution of these secondary lesions is not random. They erupt precisely along the Langer lines of cleavage on the skin.
Those are the invisible tension lines that naturally curve downward and outward from the spine, right?
Exactly. So when the oval lesions align themselves along these curving paths on a patient's back, it creates the classic Christmas tree appearance.
The morphology of the individual secondary lesions is really unique, too. They exhibit fine scaling with what's often described as cigarette paper central wrinkling. But the finding you really need to look for in the vignette is the Collarette scale.
Yes, the Collarette scale is an absolute hallmark clinical finding.
So imagine you have a blister on your hand. It's completely popped, all the fluid has drained out, and the center of the skin is completely dried up.
Okay, I'm picturing it.
What you're left with is a delicate ring of dead, lifted skin at the very edge of where the blister used to be, and it's peeling inward toward the center. That is a Collarette scale. The outer edges of the scale are attached peripherally to the healthy skin, but the inner margin is lifted, detached, and pointing toward the middle of the lesion.
That's a really vivid way to picture it. And if you were to biopsy a Pityriasis rosea lesion, which, by the way, is rarely necessary unless you're trying to rule out a dangerous mimicate, the pathology report would note the absence or regression of the granular layer in the epidermis.
What else would you see?
You would also see extravasated red blood cells in the dermis. And extravasated simply means that the red blood cells have leaked out of the porous, inflamed capillaries and basically spilled into the surrounding dermal tissue.
Okay, but because PR is primarily a clinical diagnosis, you really have to master the differentials. You have to know what else looks like a diffuse, scaly rash on the trunk. You have guttate psoriasis, which is a drop-like rash that typically erupts after a strep throat infection. You have dermatophytosis, which is a fungal infection like ringworm.
True.
But the ultimate trap the MCCQE will set for you is secondary syphilis.
Oh, yes. A diffuse, scaling, papulosquamous rash on the trunk is secondary syphilis until proven otherwise on an exam.
So when you're reading a paragraph on a screen, how do you reliably differentiate a viral PR eruption from a dangerous secondary syphilis infection?
You look at the extremities. Pityriasis rosea primarily involves the trunk and the proximal extremities, like the upper arms and thighs. It almost universally spares the palms of the hands and the soles of the feet.
And secondary syphilis famously targets those exact areas.
Exactly. The sparrow-shaped bacteria that cause syphilis, Treponema pallidum, they have an affinity for the specific vascular beds and lower temperatures found in the palms and soles. So if the vignette explicitly mentions scaly copper-colored lesions on the palms or the soles, you are dealing with syphilis, not Pityriasis rosea.
That is a golden rule for the exam. Assuming you've ruled out syphilis and confirmed Pityriasis rosea, how do we manage it?
Well, it's entirely self-limiting. The rash lasts about 5 to 8 minutes and then fades away on its own without leaving scars. The absolute mainstay of treatment is just patient reassurance.
So just general skincare.
Yeah, you recommend general skincare, emollients, and moisturizers to protect the skin barrier. Now, if the patient has severe pruritus, which occurs in roughly 25% of cases, you can offer topical corticosteroids or oral antihistamines to calm the itching.
Are there any antiviral options given the HHV link?
There's actually emerging evidence that prescribing macrolides or a cyclover might speed up the resolution of the lesions, presumably by suppressing that underlying HHV6 or HHV7 viral activity.
Interesting. Now let's talk about the OSCE, the Objective Structured Clinical Examination. This is where you're in a room with a standardized patient acting out a clinical encounter. If this rash is just going to go away on its own, what specific instructions do you need to communicate to that simulated patient to score full marks?
Communication and education are your primary tasks here. You must explicitly reassure the patient that the rash is completely benign and, despite its dramatic appearance, it is non-contagious. They're not going to transmit it to their family members or coworkers.
But is there anything they should avoid doing?
Yes, you must warn them to actively avoid environmental triggers that exacerbate the rash and delay the healing process. So instruct them to avoid hot water showers, harsh alkaline soaps, tanning beds, and excessive sweating from heavy exercise.
Basically anything that irritates the skin.
Right. All of those factors increase local inflammation and irritate the sensitive lesions.
Are there any serious complications we need to keep in mind for PR? Like, does it come back?
Recurrence of the disease is extremely rare, happening in less than 5% of patients. In dark-skinned individuals, you may observe post-inflammatory pigmentary changes as the lesions resolve, similar to Lichen planus. But the most critical high-yield complication involves a very specific patient population.
Ooh, weight population.
Pregnant patients.
Yeah.
If a patient contracts Pityriasis rosea during pregnancy, specifically within the first 15 weeks of gestation, there is a documented severe risk of premature delivery or fetal demise.
Oh, wow. Why does that happen?
The prevailing theory is that the reactivated HHV6 or HHV7 virus can cross the placenta and trigger a severe inflammatory response in the fetal tissues or the placenta itself during that vulnerable early developmental window. It's a rare complication, but because it's so severe, it is highly testable.
Absolutely something to watch out for. All right, let's do a rapid synthesis of the highest yield takeaways for the MCCQE test taker today. We started with Lichen planus. Remember the 6PS, purple, polygonal, planar, pruritic, papules, and plaques.
Look for the Wickham stria on the mucosa and the Koebner phenomenon from scratching.
Always check the patient's history for hepatitis C or ACE inhibitors. And remember to use topical clobetasol for symptoms, but absolutely never treat asymptomatic oral lesions.
Then we followed that with Pityriasis rosea. Watch for the viral prodrome followed by the large herald patch. 1 to 2 weeks later, the secondary Christmas tree pattern erupts along the Langer lines, featuring that inward peeling collarette scale.
Manage it with reassurance and avoidance of heat, but always rule out secondary syphilis by checking the palms and soles.
For Canadian medical students, mastering these specific visual findings, understanding the cellular mechanisms beneath them, and identifying the historical clues is really the key to conquering S10 dermatology efficiently.
Yeah, you aren't just memorizing lists of symptoms. You're learning how to decode the pathophysiology hidden in plain sight.
The skin tells a highly detailed story if you know the vocabulary.
That's a great way to put it. Before we wrap up, I want to leave you with a final fascinating concept to mull over. We've talked extensively about how Pityriasis rosea follows the Langer lines of cleavage on the skin, creating that distinct Christmas tree pattern.
Right.
But take a moment to wonder why. Why does a reactivated virus like HHV6 perfectly map itself onto these invisible tension lines? These lines actually represent the orientation of collagen fibers in the dermis, which are laid down structurally during our fetal development.
It's kind of incredible when you think about it.
It is. By erupting exactly along these lines, the viral inflammation is essentially painting a picture of our embryological skin development right on the surface of our bodies. It makes you realize the skin isn't just a canvas for disease, it's an architectural map of our origins.
Even when the diagnostic landscape feels like murky waters, there's always an underlying architecture waiting to be seen. You just have to know what to look for.
Thanks for diving deep with us today. Keep studying, trust your preparation, and we'll see you on the next deep dive.